Well, thank you. It's really great to be back here at Mount Sinai. Thank you, Dr. Maron, and all the course organizers for having me. So I was asked to speak about balancing efficacy and bleeding in PCI, a big topic, for 10 minutes. My disclosures, I work with a number of different companies on this area. So let me say a word about Kangol. This is a intravenous ADP receptor antagonist, very short half-life. It is completely out of the system within 60 minutes. Unlike, say, 2B3 inhibitors, similar potency, but much quicker offset of action and therefore a lower risk of bleeding. As far as new data that have come out, since I was asked to provide an update, these are some data that came out in CIRC examining the effects of Kangol versus clopidogrel in a PCI population, looking at different definitions of MI, looking at the protocol-defined primary endpoint, which was positive, which is what led to the FDA and EMA approval of the drug, but then looking at more specific endpoints, taking out things like intraprocedural stent thrombosis, taking out periprocedural MI because some people don't like that endpoint, looking just at quote-unquote hard endpoints like death, MI with symptoms or ECG changes, ischemia-driven revascularization, ARC-defined stent thrombosis. The trial remains positive. The absolute event rates come down, but the degree of benefit, if anything, the odds ratio gets smaller. That is, the degree of benefit larger. So across a variety of different sensitivity analyses, the trial results seem pretty robust. So a fast-acting agent that reduces important ischemic events. Let me say a word or two about ticagrelor, another important drug in the armamentarium of the interventionalist. I won't review all the older data, but focus on some registry data that just came out about a few months ago from our European colleagues from the Sweetheart Registry. And this is just from the accompanying editorial. What Sweetheart did was take real-world patients and see how they did if they were on clopidogrel versus ticagrelor. Obviously not a randomized trial, it's a registry. But nevertheless, interesting, large population, 45,000 patients, and the degree of benefit that they saw for ticagrelor over clopidogrel was at least as much as the benefit seen in Plato. In fact, the absolute and relative risk reductions seem to be larger. Also a benefit in stroke, which was not seen in Plato for ticagrelor versus clopidogrel, but noted in the Sweetheart study. And major bleeding was lower in the registry comparison of ticagrelor versus clopidogrel in the trial. Of course, have to take it with a grain of salt, but I think it's reassuring that real-world data look at least as good as it did in a clinical trial, both in terms of the efficacy profile, but also the safety profile. So it does seem that what was observed in the trial is translating into real life, which is always reassuring. I've actually changed my talk 3 times through the course of the day. I was going to talk a lot about risk scores, but I thought Dr. Steg did a really nice job with that, so I won't cover the other risk scores. But this was something I mentioned when Dr. Moran was just asking what I do in practice, and I said I sort of eyeball the patient and decide whether they're at high or low bleeding risk. But one specific question that she asked was how should we integrate the anatomy? And this is the work that I was mentioning from Antonio Colombo and colleagues, where really elegantly, I think, in a pooled analysis of a number of the different stent trials, they examined duration of DAPT, net clinical benefit, as a function of high-risk procedural characteristics, multiple stents, long CTOs, bifurcation lesions, the usual sort of suspects. And what they found was that the higher the number of high-risk procedural characteristics, the greater the net clinical benefit. If those characteristics weren't present, there was no net clinical benefit favoring protracted dual antiplatelet therapy, whereas if there were 1 or 2, and especially if there were 3 or more, then going longer than 12 months of DAPT seemed to make sense. And a point that I made before on the panel, I'll just emphasize, I don't think this is all a stent story, because obviously if you need a bunch of stents, that probably means you have a lot of coronary artery disease, high plaque burden. It's both those things in concert that I think predict the benefit of protracting the dual antiplatelet therapy. So I'm going to shift gears now to another area where balancing efficacy and bleeding is challenging, and that is how to integrate the oral anticoagulants in those patients that have AFib. This came up a little bit during the panel before, where we had a bit of discussion about it, and it was mentioned that the Pioneer trial had been completed and presented, And just a quick recap of that trial in case anyone missed it, over 2,000 patients with AFib getting stented randomized to conventional periods of triple antithrombotic therapy, that is aspirin, clopidogrel, and warfarin with a goal INR of 2 to 3, so what I would call the standard of care, at least in many practices, for 1, 3, 6, 12 months, it varies around the world, and there's been some evolution, but this is what the trial had as its anchor control arm, an aspirin, clopidogrel, very low dose rivaroxaban arm, and then a double antithrombotic strategy, rivaroxaban at a lower dose than the usual 20 for AFib, and clopidogrel in concert with dosage adjustment for renal function. So the trial overall was positive. There was a significant difference in clinically significant bleeding versus the conventional triple therapy arm for the Riva plus DAPT arm, as well for the Riva plus clopidogrel arm. So both arms won versus the control arm. That was the point I was making before, that there was a clear loser, that is conventional triple antithrombotic therapy. And this slide just summarizes those facts, that both those arms looked pretty good compared to the control arm. What about CV, death, MI, or stroke? No detectable difference in the overall trial, not really powered to look at subgroups such as high CHADS, VASC scores. And in a subsequent analysis that Dr. Gibson, Meron colleagues did, that I think was perhaps even more informative than the primary publication in the New England Journal, was an analysis of all-cause hospitalization and all-cause death. And that important metric, I'm not sure this is as much the case in Europe, but in the US, we really get dinged if patients get readmitted to the hospital for any reason after we do a procedure on them. But even by this endpoint, clearly both the experimental arms beat the control arm. And what I think is really quite an informative analysis, not just for the drugs, but conceptually, is this one that shows a reduction both in cardiovascular specific hospitalizations with both the experimental arms versus control, and also bleeding-related hospitalizations. So bleeding-related hospitalizations, perhaps you'd expect that from a less intense therapy. But the reduction in cardiovascular hospitalizations, I think, is really intriguing. And it really, I think, confirms and corroborates what people in the field, really what you, Roxana, had hypothesized years ago, that bleeding really does matter, and somehow, even if we don't totally understand the ways, translates into cardiovascular events, serious cardiovascular events. And there's an interplay such that we can't just think about one side of the equation. And I think there's a definite conclusion one can reach from PIONEER, even in the absence of further data, and that is that full-dose triple therapy should be dead. The reason why PIONEER showed us less mortality or hospitalization with the two experimental arms, neutral effect on mortality, significant reductions in bleeding hospitalizations and CV hospitalizations, no impact on other hospitalizations, which is reassuring because there shouldn't really be an increase or a decrease. And one would presume then a reduction in hospital costs and just an easier regimen than worrying about triple therapy with warfarin. There are other trials along the way. I don't know if the ESC template of trials is out yet, but there should be on, hopefully, Redual PCI, which is basically PIONEER, but with dabigatran instead of rivaroxaban. Other trials that are a little further along the way, such as Augustus, looking at apixaban versus warfarin, but then a factorial design with aspirin versus placebo. So that'll be interesting. And Entrust, which is the most recent trial with edoxaban in the mix. Also another recent trial, Renal AF, that's going to look at patients on dialysis and compare warfarin and apixaban in those patients. And finally, the COMPASS trial, which should be presented at a major meeting soon, is going to be applicable to a lot of PCI patients because it's a trial of CAD and PAD patients randomized to aspirin, low-dose rivaroxaban, or aspirin plus very low-dose rivaroxaban. So I think this trial will give us a lot of insight. So finally, just in terms of bleeding reduction strategies, I didn't have time to go through everything that one needs to consider, but obviously vascular access matters. Radial access has been a huge advance. When you're using aspirin, use the lowest available dose, minimize the duration of DAPT. preferentially use clopidogrel over prasugrel or ticagrelor if patients are at high bleeding risk, whereas if they're not, use the other agents. In patients that are being treated with warfarin, you might target a lower INR, though within the therapeutic range. If you're using a NOAC and combining with DAPT, which in general I wouldn't, but if you're going to, then use the lowest possible dose of NOAC. And finally, don't forget about proton pump inhibitors and avoiding NSAIDs. Thank you very much for your attention.